So today I'll be giving a little bit of an overview about geriatrics and then talking specifically about the age-friendly health systems and the 4Ms. I want to acknowledge our sponsors, the Administration for Community Living, Catholic Charities, Hale Kuike, and also from my own department, the Pacific Islands Geriatric Education Center, and also all the federal grants that support these types of presentations. These are our learning objectives for today. I'd like you to understand about population aging and specifically that older patients have unique needs, to learn the concept, which is relatively new, about the age-friendly health systems, learn about the 4Ms, which are what matters, medication, mentation, and mobility. And then specifically, because they wanted me to, I'm going to focus a little bit more on memory loss, dementia, and caregiving. I just want to say that each of these topics could be a talk in itself. So I'll have to necessarily keep it kind of short. But if you do have needs for any of these topics in the future, I'll be very happy to address any of them. I'm going to start out with what is geriatrics? People always ask me that. What exactly do geriatricians do? What is the field? So I say that this cartoon illustrates it better than anything I can say. So this older couple is sitting at a counter, and the guy says, "Judy, do you see that elderly couple down at the other end of the counter?" And she says, "Yeah, what about them?" And he says, "I was just thinking that's probably what you and I will look in about 10 years or so." And she says, "You do realize that's a mirror at the end of the counter, don't you?" So I always say is old age is 10 years older than you are at the current time. I remember when my daughter was in kindergarten, the high school seniors seemed really, really old to her. And then as she went through high school, some of her teachers seemed really old to her. And to me, they were really young because they were in their 20s and 30s. So I think age is definitely a relative term. So in general, geriatrics is the care of older patients. And the traditional age that has been used, the cutoff, has been 65 years and older. But really, that's a very artificial cutoff. It was because in the 1930s, when they first came up with the Social Security program, and then a few decades later with the Medicare program, that they picked the age of 65. Because at that time, very few people lived to the age of 65. So it was kind of, when Social Security was first created, it was kind of like your reward for living into this extreme old age of 65, that they'd give you Social Security and later Medicare. Well, now we know that the majority of people live to be 65 and older. So actually most 65-year-olds don't really need the care of a geriatrician. Geriatrics is currently a critical shortage specialty. It's federally designated as such. The need in the US is currently thought to be 30,000. We have less than 7,000, and the number is actually going down each year, while the number of older people is going up each year. So you can see that the gap is increasing. So for many practical reasons, geriatrics is currently mostly care of the very frail old. Also, we do a lot of dementia care, no matter what the person's age. Currently, there are over 50 million people over the age of 65, and it's about 15% or a little more of the population. But this is certainly projected to increase. So by 2040, this number is supposed to get to about 80 million, and by 2060, about 95 million. Hawaii is the oldest state in the US. We have the longest life expectancy for sure. This is what the life expectancy is at birth. So if you look in the year 1900, you can see that most people didn't even make it to 50. This was the average life expectancy. For males, it was 47, and for women, it was just about 50. But in about 100 years, we've almost doubled that. Not quite, but we've gotten much higher. So now in 2020, for men, the life expectancy is about 76, and for women, it's about 82. So you can see that this is, again, even by 2050, expected to increase as well. This is the US older population in a graph. So here on this axis down here is years. So this starts at 1900. This is 2020 where we are at right now. And then this is number of million people. And this blue line here is the 65 and over. You can see it's been steadily rising from 1900 until about 2010. And then you see that this line actually gets a little steeper. This is the baby boomers. So this is about 20 years of baby boomers where the numbers have dramatically increased, and then it kind of slows down again after that. And this lower line, 85 and over, that's in green, you can see that's been dramatically increasing as well. And this is where actually Hawaii has many older people who are not just over the age of 65, but over the age of 85 and even centenarians. So this is Hawaii's graph of the older population, starting in 1960, and then you can see here we are in 2020 here. And in orange is the state of Hawaii, and in purple is the US. So I was actually surprised at this. Until the 1990s, until the mid 1990s, the percentage of the population that was older was actually lower than the national average in Hawaii. And then after somewhere in the mid 1990s, this switched. And now our rate of growth is much higher than the national average. This graph really tells you how the population is changing in the United States. So this was 1960 and this is 2060. So this is a projection, of course. And you can see here, these are the age groups. At the bottom, we have children. The first four bars are children. And then we go into adulthood and then middle age, and then now the older population going all the way into the 85 plus. And you can see the population used to be a pyramid. So mostly we had children, and then less and less as the ages got older. And the percentage of people in the extreme old ages was actually quite small. And we're not quite there yet, but we're almost there. Look at this. This is no longer a pyramid. This is more like a rectangle, where now we have children are actually less than maybe some of the people in young and middle ages. And even the older population is much higher as far as the percentage of the population. So there are some specific characteristics of aging that we see. Older people in general tend to be more susceptible to disease. So as time goes on, they kind of gather more comorbidities. Genetics is extremely important. In fact, if you ask me for a single factor that predicts whether somebody will live to extreme old age, it's actually probably genetics. But it's not only genetics. I want to make sure that people are clear about that. There's a lot we can do about whether or not we age and whether or not we age successfully. So environmental factors, our lifestyle habits over our entire lifetime, how we eat, how we exercise, whether or not we smoke, those kinds of things make a huge difference as well, and they influence the rate of aging. One thing that we see consistently among populations is there's great variability among older people. So let's say I take a group of 20-year-olds, 100 20-year-olds, and I measure anything on them, whether it's heart function or kidney or lung or anything, they'll be very close to each other, the measurements. So in general, they'll be very much like each other. If I take a group of 80-year-olds, 180-year-olds, and I measure any of those things, now we find a huge variability. We'll find some who are completely normal. So their kidney function, even at the age of 80, might be completely normal. Or we'll find some that are extremely abnormal and everything in between. So the spread and the difference between older people is really high. The ability to maintain homeostasis decreases. What is homeostasis? This is the body's ability to balance things. So for example, let's say you go outdoors and it's a bright sunny day and it's hot. Your body has to make some adaptations to adapt to that heat. So if you're exercising and it's hot, you'll be sweating to let off heat out of your body. Your other organ systems will be doing other things to kind of maintain this homeostasis so you don't have problems. Well, when you get older, this ability to maintain the homeostasis decreases. So you get into trouble much easier, which is why at extreme cold, at extreme heat, whenever anything happens, it's usually the very old and the very young that are affected the most. This graph gets at common disabilities by age. In the dark green are males, and in the light green are females. And this is hearing, vision, walking, cognitive problems, whether or not you can live independently, and whether or not you can take care of yourself. And for each of these graphs, it starts with the age 5 to 17. So this is children, and then it gets older and older. This is the 65 to 74, and this is 75 plus. And each of these graphs is set up in exactly the same way. So you can see very little disability in childhood, of course, for any of these, a little bit more in adulthood. After you hit the age of 65, you can see more and more difficulty. In general, for all of these, women have more problems than men do, except for hearing, where usually men have higher disability in hearing than women do. But you can see how common these are. So when you hit the age of 75, for women, it's almost 20%, and for men, it's almost 30% for hearing difficulty. For vision, it's about 10%. For walking, it's between 25 and 35%. Cognitive, between 10 and 15%. Trouble living independently, again, between 20 and 30%. And with self-care, around 10 to 15%. So you can see after the age of 75, some of these disabilities do become quite common. So these are the principles that we use for geriatric assessment. Our goal is not necessarily to keep people alive forever. It's more to promote wellness and independence. Our focus is not just organ systems, it's looking at the whole person and their functioning. So our scope is very wide. We look at physical, cognitive, psychological, and social domains. Our approach is interdisciplinary. We need a whole team of people to take good care of older people. And our success is measured not by length of life, but by maintaining or improving quality of life. And we find that for most older people, that's what's most important to them, is quality of life. So the approach is focused on the whole person, not an organ system, to enhance independence and quality of life. We do a lot of preventive care, a lot of rehabilitation if possible. And at the end of life, we do a lot of palliative care with an interdisciplinary team. So now I want to introduce the concept of age-friendly health systems. This is based on the premise that older people have unique needs. And this initiative was actually created by the John A. Hartford Foundation. By the way, my department at JABSOM is a John A. Hartford Foundation Center of Excellence in Geriatrics. We were designated as one of the 25 centers around the country. So the Hartford Foundation, the Institute for Healthcare Improvement, the American Hospital Association, and the Catholic Health Association of the US created this initiative. The goal was to prevent harm and to improve health outcomes and lower costs for care of the older population. It's really the same things we've always done, but done in a new way to organize care for older people in a very specific way. The country's goal is now that this should be implemented in all settings, including the home, community, nursing homes, as well as hospitals, not just the hospital setting. And they think that this will help meet the goals of the IHI triple aim, which is improving individual healthcare, improving health for the whole population, and reducing costs of care. So this is a diagram of the 4 M's of the age-friendly health systems. What matters? Medication, mentation, and mobility. I'll go into each one of those. So what matters is really at the center of this 4 M's, because no matter what, that's the most important thing, is what matters to this patient. We need to ask them that. We should not make any assumptions. We need to ask what matters, not just for their healthcare goals and for their care preferences, but even for other things in their life. Things like their family and friends. What's the most important thing to them? And this can be very different from person to person. I want to touch on these concepts, getting advanced healthcare directives, doing POLST. I'm going to talk about both of those in a little bit more detail in future slides. I really encourage people to talk to their family. I have a really hard time convincing them sometimes because they say, my kids don't want to hear about what's going to happen to me when I get sicker or when just before I pass away. They think it's bad luck. And I always tell them, no, please try talk to them because it's really important that the whole family is in sync and supports what the older person wants. What matters is the most important M. All of the other M's should really revolve around what matters to that patient. So let me start with advanced directives. These are all directives, instructions, or even desires that a person may communicate about their wishes for medical treatment. Now, this can only apply under certain conditions. So this is a sample advanced care healthcare directive form. So you have the personal information, and then it asks about whether or not you want to prolong your life. If you have an illness that is kind of not going to be fixable, basically. Do you want artificial nutrition and hydration? For example, do you want tube feeding? Do you want relief of pain, even if that may hasten your death a little bit? Are there any specific religious instructions? So there's a lot of different types of advanced healthcare directive forms. The one that I really like to use is the one on the Kokua Mao website. So I strongly encourage people to go to that website. You can download a form from there if you'd like to. Now, the format of advanced directives can be either written or oral. I really recommend highly to do a written one if possible, but some people just never get to that. So even if you talk to your doctor about it and they document it in their chart, that's considered a legal document. So written is much better because then there's no question about what the wishes are. Sometimes people can even write it in a letter expressing their wishes. Durable power of attorney is also important because these documents can never cover every single possible thing that might happen to you. So it's really good to select one or sometimes more than one person to be your agent. So if there comes a time when you're unable to make decisions about your own healthcare, then this person or these people can speak on your behalf. So again, all the more reason why you need to communicate with them, right? They need to know what you want so that they can tell the doctors and others the same thing. Now, this person could be your spouse, it could be an adult child, it could even be a friend or any other trusted person, but it shouldn't be an employee of the healthcare facility. It shouldn't be your doctor who's your power of attorney. It should be somebody personal in your life. It must be signed and witnessed or notarized. The POLST stands for Provider Orders for Life-Sustaining Treatment, and this is actually an order from a physician or a nurse practitioner, and it specifies the types of treatment that a seriously ill person wishes to receive right now. This is really nice to have, particularly for the community, if somebody calls 911, for example. So let's say you're at home and something happens and somebody calls 911. When the EMS arrives at your door, if they see this POLST, they will actually follow this order. So if the POLST is signed by you and your physician and it says, I do not want CPR, they will not do CPR. If they don't see this POLST, even if you tell them that, they will probably, if somebody tells them that rather, because obviously you can't because you're not conscious. If somebody else tells them you don't need to do CPR, they will not listen to them, but they would if you had this POLST. It's purposely in this bright lime green color so that it's easy to spot, and it needs to be put right where people can see it. So most people will put it either right on their refrigerator, on the back of their front door, or somewhere where it's very easy to find. And it says whether or not you want CPR, what types of medical interventions you want, whether you want tube feeding, and then this talks about This is all the different signatures. It talks more about your medical condition. Needs to be signed by the physician or the advanced practice nurse. So what's the difference then? I talked about advanced directives and POLST. Should you have both? Well, it depends. Who needs to have an advanced directive? Really, it should be all adults. I had one when I was a very young person, even though I was in completely good health, but I had one just in case, because this is for the future and bad things can happen even to young people. So it's good to have this for every adult should really have this. A post really needs to be for persons with advanced illness, no age restriction, because sometimes, unfortunately, we can have even very young people, even children, who have a very serious illness, which could be life threatening. So, this post is more for people with advanced illness. The purpose of the advanced directive is to express your values, to appoint your decision maker, and to talk about your future wishes. Whereas the POLST is medical orders that apply right now. The advanced directive will not guide the EMS actions. Even if you have an advanced directive, they will not follow this. If they come to your door, they will start CPR unless your POLST says you don't want it. Both of these will guide treatment decisions in the hospital. Let's move on to the next M, medications. Well, older people use a disproportionate percentage of medications. So even though they're about 15, 16% of the population right now, over 1/3 of prescription medications are taken by people over the age of 65. And over 90% of older people take at least one drug. Polypharmacy, or taking multiple medications, is unfortunately very, very common. Drug interactions and side effects are also more common with age. So, what is successful drug therapy? I always compare it to a bullseye. To hit that bullseye, you have to have the right drug at the right dose for the right condition and the right patient and their goals of care. And failure in any of these can lead to ADE, which is adverse drug events. Unfortunately, these are extremely common. They're responsible for 700,000 ER visits and 120,000 hospitalizations each year in the United States. A really big problem. And not only does it cause a lot of misery, it's also very expensive. $3.5 billion are spent each year on adverse drug events. It's sad because many of these are very preventable. And who's the most vulnerable? Of course, are older patients. They're the most prone to having these adverse drug events. And they're also the least likely to be able to deal with them well. So again, prevention is really, really important. These are some of the risk factors for adverse drug events. Advanced age, the more medications you take, whether they're prescription or over the counter, the more likely you are to have an adverse drug event. If you have a prior drug event, the same class of medications will more likely cause a new one as well. That's why history is so important. That's why your doctors will always ask you, did you ever have a problem with this type of medication before? Use of alcohol is also a risk factor. Low body weight, which is so common among our Asian population here in Hawaii. Poor liver or kidney function, because the liver is what metabolizes most medications and the kidney is what excretes most medications. So again, if those don't work well, more of the drug builds up in your body. So these are the rules for drug use in the elderly. Start low and go slow. Always look at risk versus benefit. Everything has risk. Even when you take Tylenol, there's some risk. It's a pretty safe medication, but there's always some risk. So you always have to look at the two and say, what's the risk? What's the benefit? If the benefit isn't greater, don't give it. Another thing about older people is don't quit too soon. Sometimes it takes longer to reach what we call steady state and to have an effect. So with older people, you just have to be more patient and see whether the medication will work. You need to monitor very closely for side effects. And in general, I avoid starting two new drugs at the same time. Now, Sometimes this is unavoidable because if you're in the hospital and you have a really acute illness, sometimes you have to start 5 drugs at the same time. But in general, if the person's outpatient, I try and do one at a time. Then if there is a problem, I'll know which one it's due to. And then this last one is actually my own rule. It's the roller coaster rule. My husband, my daughter, and I, all 3 of us, we really love roller coasters. And I love those crazy ones, that kind of spin you around and twist you all over the place. And many years ago, my husband and I made this decision, like when we go to amusement parks, if there's a brand new roller coaster, we won't ride it in that first year because that's when most of the problems happen. We've broken that rule sometimes because we've been very tempted. But in general, for older people, when a new medication comes out, for the most part, I don't use the new medication for my older person right away because by the time a drug is FDA approved, it's only been through a few thousand people. And sometimes the rarer side effects haven't come up yet. So I don't want to test it out on my very frail older patient. So I wait and I don't start new medications unless there's no other choice. So there have been exceptions when there's no other medication available for that condition. And then, of course, I have broken that rule. But in general, I try to wait and be more patient. So for appropriate drug use, we always ask, is the medication necessary? What are the goals and what are the endpoints? For example, for blood pressure, the endpoints might be very different for somebody who's 50 or somebody who's 80. Same thing with cholesterol management. The goals might be very different for the 2 age groups. Do the benefits outweigh the risks? Are you treating the effects of another drug? I usually don't like to do that. If I'm having a side effect from a medication, I'd rather cut back on that medication than add a new one to treat that side effect. Could one drug be used for 2 conditions? And are there possible drug or drug disease interactions? Always ask that question. Moving on then to mentation. The goal is to prevent, identify, treat, and manage dementia, depression, delirium across all settings. So older people are certainly more prone to all of these conditions. I'll start out with depression. So what is it? It's a medical condition that causes mood changes with persistent feelings of sadness and loss of interest. In older people, this can be missed sometimes. You have to specifically look and ask about depression. People won't tell you. And sometimes in older people, they won't tell you about persistent feelings of sadness. It'll be more this sort of loss of interest. So again, it needs a little bit of skill, but it's very important to identify depression as early as possible and to give treatment as early as possible. Depression can affect how you feel, think, and act in daily life. It can affect your functioning at work and at home, can cause you problems with relationships. So this isn't just, all of us say sometimes, right? Oh, I'm so depressed today. It's not that kind of casual feeling of I'm not feeling great today. This, to be a clinical depression, it needs to be present most of the time, nearly every day for at least 2 weeks. So this is just a little cartoon. The doctor's asking, depressed, not sleeping, low self-esteem. Still, enough about me. What can I do for you? So what is delirium? Delirium is an acute confusional state. It comes on quickly, over hours or days. There's a clouding of consciousness. So sometimes these patients will be very lethargic and almost like you can have a hard time even waking them. And sometimes they'll be hyper alert and really agitated and almost like bouncing off the walls. So you can see this waxing and waning with both extremes happening. You can see a severe attention deficit. So it's very hard to even have a conversation with these patients. It's very hard. I have students who come back and they're trying to do a formal mental status test, and they come back saying, I can't do it. And I say, that in itself should tell you something. If they can't even do the test, it tells you that their attention is really impaired. These patients have a very altered sleep-wake cycle. So often they'll be sleeping all day long and then up all night, very agitated. This condition of delirium is very common in the hospital. And it's particularly common in those who have an underlying dementia, particularly Alzheimer's disease. And so when we see this is supposed to be a medical emergency that we need to jump on quickly and try and treat as quickly as possible. Let me move on then to dementia. First, what is it? So for dementia, we need to have acquired deficits. So for example, somebody who has lifelong intellectual problems like mental retardation, that doesn't count as dementia. This is changes for somebody who was previously normal. You see a deficit in memory, but at least one other cognitive domain also needs to be affected, like language or visuospatial ability or ability to plan tasks, those kinds of things. So you need to have both memory and at least one other thing. It needs to be bad enough that it's affecting your social functioning with your family and friends, or if you're still working, it's affecting your job performance. And you need to have an absence of delirium or major psychiatric disorders like depression. So if you have delirium or depression, you can't make the diagnosis of dementia yet. You can suspect it by history, but you have to wait until the delirium or the depression are treated, and then you can make the diagnosis of dementia. There's also this condition called mild cognitive impairment, or MCI. This is a subjective cognitive complaint. It can be done by the patient. So it could be the patient saying, my memory is bad, but even more often, it's usually the proxy. It's usually a family member. So particularly in a condition like Alzheimer's, often the patient will have no insight. And so they will tell you, when you ask them, they'll say, oh, doc, my memory is great, because they don't even realize they have a problem. But you can see the spouse in the background shaking their head going, no, it's not great. You have a cognitive deficit on testing in at least one domain. This can be memory, language, attention, executive function, visuospatial ability, any of these things. So on testing, the person has a problem, but they have normal social and occupational functioning. Because remember, if their functioning was impaired, they'd have dementia. So these are people who have some impairment in testing. They may have some complaints, but they're functioning okay. This is kind of like a pre-dementia. And these patients do have a high risk of converting to having dementia, usually Alzheimer's. It's at about 12 to 15% per year will convert. So within 5 years, about half of people who have MCI will have converted to have a diagnosis of dementia. Why one half and not the other half? To be honest, we don't know. That's a really hot area of research right now. Like what can predict and how can you prevent switching over from MCI, where you're still functional, to dementia, where your functioning is really badly impaired. Dementia, unfortunately, is a very common condition in old age. It's about 13% in this country over the age of 65. But when you hit the age of 85, it's almost 50% of people who'll have this diagnosis. We see a geometric increase in prevalence of dementia. After the age of 60, the prevalence doubles every 5 years. I have this in a graph form in the next slide, so I'm going to just show you that. Oops. Okay, so on this axis here, I have age. So this is from 60 to 65, all the way up to 85. And here is, on this axis is the percentage of people with dementia. So you can see at the age of 60, it's actually very uncommon. And then as this age goes up by every 5 years, it doubles. And so this curve is quite steep. It's not a straight line, it's a curved line because it's going up quite exponentially. This blue bar is people who meet criteria for dementia. So it's affecting their social and occupational functioning. It's about 1/3 of people by the age of 85 will have this. These include the MCI. So you can see if you include MCI, it's almost half of people. Very, very common condition. The reason why this goes up so exponentially is there is a long duration of disease, particularly with Alzheimer's disease. People can live with Alzheimer's for years, for decades sometimes. I've seen people who've had the diagnosis for 20, 25 years, sometimes even more. So it's not something, it's something you live with for a very long time for most people. There are some who have a shorter duration, but for many, it's very long. It's a very devastating condition. It's a major cause of disability, and it's the primary reason for being institutionalized, either in a care home or a nursing home. In this state, it's estimated that about 75 to 80% of people in long-term care are there because they have dementia. And it's an expensive condition, over $200 billion annually for care, and the same amount for lost productivity, sort of indirect costs, because often family members are affected by this too, because they have to become caregivers. Often they'll have to take early retirement, or they sometimes have to take leave from their jobs in order to do the caregiving. I want to really focus on this slide. Not all dementias are Alzheimer's disease. So I want to kind of stress this. Dementia is the umbrella diagnosis. There are several types of dementia that we see. The most common is Alzheimer's disease, seen in about 60 to 80% of all dementias is Alzheimer's disease. The next most common is vascular dementia, which is related to strokes. There are other less common ones, Lewy body dementia, frontotemporal, a whole bunch of others. And fortunately, there are some that are actually reversible or treatable. Not that many. The percentage of treatable dementias is actually quite low, unfortunately. But if you are one of those, of course, you want it found as early as possible. So the major dementia subtypes, if you look at this pie chart, in white populations, by far the most common is Alzheimer's disease. That's seen in the blue. It's about 2/3 to 3/4 of dementia is Alzheimer's. Vascular or stroke-related dementia is the next most common, about 10 to 20%. In Hawaii, we've done studies that have found that in our Asian populations, vascular dementia is a little bit higher than this. Alzheimer's is still number one, even in the Asian populations, but vascular becomes more common because stroke is more common. And we find that some of these people may not even have a history of stroke. They have what we call subclinical strokes. They were silent strokes. And so sometimes we only find it when we do scans of the brain. So it's really important that we detect this early. This small little wedge here of yellow is Parkinson's disease and the other Parkinsonian syndromes, which cause dementia. And then this green is mixed and other dementias. So for treatment strategies for dementia, early diagnosis is really key for dementia. If there's a cause, you need to treat the cause. We always treat complications of dementia, behavior, sleep problems, because those can be very, very troubling, not only to the patient, but to the family members who are taking care of them. Safety is a huge issue. We need to provide a safe and stable environment, and that's a huge focus of dementia care. Family education is very important. Usually when I first make that diagnosis, right after that, I ask for a family meeting and I ask for as many people in the family as possible to come, because this is not something that's going to be over quickly. We know that dementia is a long diagnosis, right? We know that people who are affected with dementia are going to be needing care for a very long time, for many years. So it's really important to get everybody on board. Caregiver support is also important. Caregiver burnout and stress is extremely common. So it's really important that we not just care for the patient with dementia, but also for their caregiver. We need a whole team. Sometimes the physician is more important, but at other times, maybe the nutritionist might be more important for the patient with dementia, or social worker to help with community resources. The community resources I often use are Alzheimer's Association, Executive Office on Aging, and many others that are out there. So if you are one of those people who does have needs, please let somebody know and they can direct you to the right agency. The other reason why early diagnosis is so important is If the patient is able, I really like to talk to them about their own advanced planning, about their healthcare planning, as well as planning for future financial and legal issues. This slide is really important, because sometimes people say, well, there's nothing I can do, right, to prevent dementia. Well, that's actually not true. There's a lot of things we can do throughout our lives to hold off dementia as long as possible. They're not 100%, but they certainly will reduce your odds. So it's important to be physically active, socially active, and mentally active. And all three of these in studies have been found. If you're more active, you have a lower chance of developing dementia. Good nutrition is also important. And the diet that's been best associated with reduction of dementia risk is actually the Mediterranean diet, which is pretty common sense. Lots of fruits and vegetables and less of the bad stuff, less of the sugar, the salt, and the saturated fats. The other thing that actually one of our studies here at Kokini found, one of the first studies that found that was reducing risk factors for heart disease throughout your lifetime can also have a beneficial effect on your brain. And this is particularly true for two, the high blood pressure and diabetes. If you have good control of those during your middle life, then your chance of developing dementia in late life is lowered. I'll go on then to the last M, which is mobility. It's very important for older people. When you ask them what's important to them, most of them say, I want to remain functional and independent. So that's something that we really need to focus on. Activities of daily living and instrumental activities of daily living, which I'll explain in a future slide. Preventing falls is important. And then talking a little bit about the interdisciplinary team care. We really work a lot with our rehab partners, occupational therapists, physical therapists, speech and language pathology, and others. So what are the ADLs, activities of daily living? This is things that you do every day. When you wake up, you go brush your teeth and you go to the bathroom and you have your breakfast, you dress, you get out of bed and you walk around, take your bath. So these are the regular day-to-day things that you do that are kind of basic activities. In general, in order for somebody to live alone, they need to be able to do all of these. The one exception could be bathing. If somebody needs help with bathing, maybe a bathing service could be brought in a few times a week. The person can still live alone. But if you can't brush your teeth and go to the bathroom and feed yourself and dress yourself or walk around, you cannot really live safely alone. So it's very important that we monitor this. These are the instrumental activities of daily living. So these are a little bit more complex tasks. Things like cooking, cleaning, taking your medication correctly, doing your laundry, doing your shopping, doing your personal finances, paying your bill, balancing your checkbook okay. Are you able to communicate? Are you able to make phone calls or return phone calls? What about transportation? Driving, or if you're not driving, that's okay, but can you take a bus? Can you take a cab? Can you call the cab yourself? Those kinds of things. It's possible for people who have trouble with some of these to still live alone if they have a lot of family support. So there are some people, as long as the activities of daily living, the first one I told you about, as long as these are okay, family can come in and help with cooking and cleaning and laundry and shopping and those kinds of things. But, even taking medications, somebody can come and fill a pill box for you, but you have to have enough memory to know whether it's Monday or Tuesday or Wednesday or whatever and what time of day it is to use that pill box correctly. Fall prevention is really critical. We know that falls can be a very serious threat to older people. In fact, sometimes falls can be that sentinel event, which lead to somebody going from being completely independent to being completely dependent. The CDC has this really good program called the STEADI Program. STEADI stands for Stopping Elderly Accidents, Deaths, and Injuries. So it's kind of a mnemonic. It has core elements, which are screening for risk, assessing older people, and then actually doing some interventions to help prevent falls. So we know that falls are extremely common. 1 in 4 people over the age of 65 falls each year. So this is not uncommon in older people. Sometimes the healthy older people have the worst falls because they're doing risky activities, like they're climbing on top of a table or a chair in order to change a light bulb or something like that. So I tell people, even if you're really healthy, please be careful because you don't want to put yourself at risk for a fall. It can really make a huge difference in your life. It's a very expensive problem as well. I think they say about $50 billion are spent annually, and it is a preventable condition. So the STEADI program has some screens asking people about just questions about whether they've fallen before or not, and then actually doing some balance and gait testing, because we can tell from somebody's balance and gait whether they're at risk for falls or not. Identifying risk factors. Medications. Some medications actually put you at higher risk for falls, particularly if they cause this condition called orthostatic hypotension. What this means is that when you're lying down, your blood pressure is fine, but when you stand up suddenly, your blood pressure really drops. That's called orthostatic hypotension. It's with change in position. And we see that sometimes at night. So somebody wakes up to go to the bathroom, they get out of bed suddenly, and they plop down onto the floor because their blood pressure suddenly dropped and they passed out. So it's really important to identify this and make sure that we give people good strategies to deal with it. Are there home hazards? Sometimes people have a lot of clutter in their homes, or they have these rugs, which might be slip hazards. So again, we often will have a home visit with a physical therapist or an occupational therapist to do a home safety evaluation for these home hazards. Vision can be a problem as well. If you can't see, of course, you might be more likely to fall. What kind of footwear are you using? Or what, you have trouble on your feet, you have something that's causing your feet to not balance well. A lot of women, they'll wear high heels, which are not great. And particularly if you're at risk for falling, I really recommend wearing no heels at all and something that's non-slip. Are there comorbid conditions like osteoporosis, which can put you at higher risk for fracture? Do you have depression, other conditions? And then the STEADI program gives interventions, prevention by education, diet, exercise programs, addressing various risk factors. And as I said again, doing physical therapy and home safety evaluations as well. So in summary then, for all practical purposes, aging is a loss of the body's reserve capacity. Normal aging should not interfere with daily activities, but we know that with age, there are more risks and exposures and therefore more disease. Our habits over a lifetime can really influence our health. The other thing I want to say is when we reach extreme old age, so I'll often have patients who are in their late 80s and even in their 90s and above. And sometimes they're doing great. They're living alone. So it's a 95-year-old who's living alone, cooking, doing their own cleaning, maybe even sometimes driving or, able to take the bus. And what happens is one event happens, and it can be anything. It could be a fall, it could be pneumonia, it could be a little heart problem, whatever. And suddenly they drop drastically. And they have a very hard time climbing back out. And the family will ask, what happened? Because they were doing fine just last week. And what I tell them is this is part of the aging process, which is it's very hard. There's no reserve for older people. So even though they're doing great, it's like they're kind of teetering at the edge of a cliff. And once they fall off the cliff, it's very hard to climb back up. So again, we want to keep our older population as safe as possible, knowing that things can happen, but try and avoid those things that we can avoid. So here's a slide I really like. I think it's very important to not stereotype older people. Here we have this older person who's in a wheelchair, who can't walk and might need help with a lot of their activities of daily living. And look at this lady. She's doing something that I never could do even when I was a younger person. So we see these extreme differences among older people. We see some who can be extremely healthy and functional and some who are not. So in summary, I think it's very important for all health systems to adapt to the age-friendly health system and the 4Ms: what matters, medication, mentation, and mobility. So far in Hawaii, through our Geriatrics grant, we have actually helped 2 health systems to achieve IHI age-friendly health system status. So the Queen's Health System is now level 2 certified. So that's the highest level, certified as an age-friendly health system. And at Palimomi, the family medicine clinic there has reached level 1, and we're hoping to get them to level 2. And we are working with the Kokua Kalihi Valley Clinic next to try and get them to the level 1. We're going to be doing, every time we can, we'll be doing more people to get them certified as age-friendly health systems so that more and more through the state can give better care to our older population. Well, I've reached the end of my talk, so I'm going to stop here and see if you have any questions for me. Thank you so much for your attention.